introduction कराऊंगा. Bismillahirrahmanirrahim. I am Professor Yakoob Ahmedani, working as a consultant diabetologist at Buckeye Institute of Diabetology and Endocrinology, and I am heading the Ramadan study group of Buckeye Institute of Diabetology and Endocrinology. I'm also executive member of Pakistan Endocrine Society, and I am also a co-author of the recently published IDF and DAR International Alliance guidelines regarding Ramadan and diabetes. Today, I will be discussing on issues related to Ramadan and diabetes. So, the prevalence of diabetes in the Muslim population is rising, and a significant proportion of patients fast during the month of Ramadan. Over the next 25 years, the increase in the number of adults with diabetes in Muslim majority regions is expected to be in excess of the global average. You can see the global average is around 55%, but in the MENA region, it's 104%. In sub-Saharan Africa, it's 141%, and in Southeast Asia, it's 79%. And quite a number of patients with diabetes actually fast during the month of Ramadan. It is estimated that around 148 million Muslims are living with diabetes globally. And the recent study, the CREED study, which was published in 2010, according to that study, 94.2% of the patients fasted for more than 15 days, and 63.6% of the patients fasted every day of the month. So quite big numbers of Muslims are fasting all over the world. While managing these patients during Ramadan, you have to consider several of the factors, like what type of diabetes they have, whether they have type 1 diabetes or whether they have type 2 diabetes or gestational diabetes. It also depends upon the glycemic control of these patients, whether they are poorly controlled or they are well controlled. What medications they are taking, whether they are on oral drugs or insulin. And also it depends what are the other comorbidities in these patients, like maybe they may be having renal involvement or cardiac involvement or liver involvement, or what other comorbidities they have. It depends. Your management differs from person to person. Then also the personal circumstances of these patients. Some patients are living alone, they are elderly and they're living alone. So you have to take into consideration all of these things while managing these patients during Ramadan. The EPIDIA study was the first study to highlight several of the characteristics of patients who fast during the month of Ramadan. It was done in 13 Muslim countries, and around 1,000 individuals were studied, and the experiences during Ramadan were collected. And it was shown in that study that around 42.8% of those patients with type 1 diabetes fasted, and around 78.7% of the patients with type 2 diabetes fasted for more than 15 days during Ramadan. And it is mentioned in that study that only 2/3 of the study population received advice from healthcare providers about diabetes management during Ramadan. And it also highlighted the fact that actually not many of the patients received education before Ramadan, and around half of the study population did not change their lifestyle during Ramadan. Hence, it was reported that higher rate of hypoglycemia and hyperglycemia were reported in that study. And I believe that this was not because of fasting, but it was because of non-preparation of these patients before Ramadan. Since this was a retrospective study, so no intervention was done in this study. It was just observations that were made during this study. So not all patients received recommendation from healthcare providers. Not all patients were monitoring in that study, and not all patients changed their medications during Ramadan. Not all patients changed their lifestyle during Ramadan. Hence, higher rate of complications were reported. And based on these findings, IDF and DAR have made risk categories. Category 1 where we have a very high risk, Category 2 where we have higher risk, and then Category 3 where you have moderate risk. And these risk groups are made on not on evidence but on experience, and these are based on expert opinions. So you can see that in very high risk category, Category 1, you have patients who have severe hypoglycemia within 3 months prior to Ramadan, or DKA within 3 months prior to Ramadan, or hyperosmolar state within 3 months before Ramadan, history of recurrent hypoglycemia, history of hypoglycemia unawareness, poorly controlled type 1 diabetes, acute illness, pregnancy, CKD stage 4 and 5, advanced macrovascular complication, and old age with ill health. So these patients are considered as a very high risk group. Then Category 2, where you have a high risk group, including type 2 diabetes with sustained poor glycemic control, well-controlled type 1 diabetes, well-controlled type 2 diabetes on multiple injections, pregnancy, type 2 diabetes, pregnant type 2 diabetes, or GDM controlled by diet only or metformin, chronic kidney disease, stage 3, stable macrovascular complications, patient with comorbid conditions that present additional risk factors, people with diabetes performing intense labor, treatment with drugs that may affect cognitive function. So these patients with these characteristics are considered as at high risk. And the Category 3, where you have moderate to low risk, where you include all those patients who are well controlled on lifestyle, metformin, acarbose, thiazolidine, second generation sulfonylureas, incretin-based therapies, SGL2 inhibitors, those using SGL2 inhibitors, and those who are on basal insulin. So these categories were identified based on the findings of EPIDAR and subsequent studies. But these are, again, not all are evidence-based, and these are based on experience of experts. And this may vary from person to person, and this may vary from country to country. So these, in other words, these are not all contraindications to fasting, and you have to individualize each patient. You have to see whether they are at risk, he or she at risk or not. Then the question arises, is it safe to fast for our patients with diabetes? So we have published this paper, the Ramadan Prospective Diabetes Study, which was published in Diabetic Medicine in 2012, where we looked into the role of drug dosage and timing alteration, active glucose monitoring, and patient education in the occurrence of acute complications of diabetes. In total, we studied 110 subjects, and we obtained around 3,946 readings from their glucometers, and only 2% of the readings were in hypoglycemic range in 27 patients. 22 episodes of symptomatic hypoglycemia and 60 episodes of biochemical hypoglycemia. 7 patients experienced symptomatic hypoglycemia, while 20 patients had biochemical hypoglycemia. The predominant episodes occur 28 episodes of hypoglycemia pre-dawn, that is before sahur, even before the start of fast, followed by midday hypoglycemia, where the episodes were 19. Regarding hyperglycemic episodes, 261 episodes occurred before sahur and 226 episodes occur after iftar. So there were hyperglycemic episodes and there were hypoglycemic episodes, but none of the patient required hospitalization because of serious hypoglycemia or DKA or hyperosmolar state. And the distribution of symptomatic and biochemical hypoglycemic episodes, there was a downward trend over 4 weeks. You can see that there was a downward trend of both biochemical and symptomatic hypoglycemia. The estimated average glucose and the mean blood glucose values of the study population, you can see that before Ramadan, it was 224 milligram per deciliter of the whole cohort, which fell to 156 milligram per deciliter, a significant fall during Ramadan. And you can see that in this cohort, you have all sorts of patients, those who are well controlled and those who are not well controlled, like patients with HbA1c of less than 7 to HbA1c of more than 11. So that was about our first study, Ramadan Perspective Diabetes study. And this is the slide I'm showing you. This is a newer study which was recently published. This study is again a prospective study on people with type 1 diabetes. Here we followed these type 1 patients, the young patients. These patients are considered as a high risk group, but again, these patients did fast, and we followed these patients for 3 months. That is Shaban, that is a month before Ramadan, during Ramadan, and a month after Ramadan. So for 3 months, we followed these patients. Again, we have educated them before Ramadan. We gave them monitors, glucometers to check their sugars during these months. And we asked them to follow the dietary advice, and all other education aspects were covered before Ramadan. And you can see that in the red ones, you have hypoglycemic episodes. 8.3% was the rate in the month before Ramadan, which dropped to 6.6% during Ramadan as a result of education before Ramadan, and it continued to improve around 5.1 after Ramadan. But there was an increment in the rate of hyperglycemia during Ramadan. You can see from 33.37% to 41.83% during Ramadan. And we think that that was because of not following the dietary advice in these young patients, and they overdo during the non-fasting hours, and as a result, they got hyperglycemic episodes. Although none of the patient went into DKA, or none of the patient required hospitalization for hypoglycemia. The HbA1c in the fasting group before Ramadan was 9.1, which dropped to 8.9 post-Ramadan, although it was not statistically significant difference, but it has a downward trend. But also in non-fasting group, you can see that it was pre-Ramadan 9.2%, and it improved or almost the same to 9.1 in post-Ramadan period, and it was also not significant. So the glycemic control did not improve either, did not deteriorate also. So the second question is about drug dosage and timing alteration during Ramadan. This is very important aspect, and every physician must know how to adjust the medications during Ramadan. This is a published study where the patients were questioned regarding their treatment changes during Ramadan, and it is already published, and it was from 2 big centers of Karachi, where the patients with diabetes were questioned about several things in their management. The question was asked, was the medication adjusted before Ramadan? 18.4% of the patients said that no, the medications were not adjusted before Ramadan. So not all patients had a change in their medication. 8.2% change in their medication dosage and timing before Ramadan. So how to do that? If they are taking metformin, acarbose, or DPP-4 inhibitors or TZTs, these four groups, if they are taking as monotherapy or in combination, these you don't have to change the doses of these drugs, just you have to change the timings of these drugs. So those who are taking it in the morning, they have to shift it to iftar. That is, during Ramadan, the morning dose will be taken at iftar, that is in the evening, while the drugs which they are taking in the evening will be taken at sahur, that is before the start of fast. That is at sahur, pre-dawn meal. Regarding sulfonylureas, if they are taking morning dose once a day, that dose will be shifted to iftar, that is, will be taken in the evening, and the dose will be slightly reduced to by 25%, that is 75% of the actual dose will be taken at iftar for first few days in well-controlled patients. Because as you know that the eating and non-eating hours are not equal. There are, in certain locations, it is around 15 hours of fasting and you have 8 to 9 hours of eating and drinking. So the periods of eating and non-eating are not equal. So you have to slightly adjust the dose considering these unequal timings of meals. So you have to slightly reduce the dose at iftar in well-controlled patients. Those who are taking sulfonylureas twice a day, the morning dose will be shifted to iftar, and in well-controlled patients, slightly reduce the dose for first few days and then adjust according to the glycemic control. While evening dose will be taken at sahur and will be halved. But remember that all sulfonylureas are not similar, and these are 3 or 4 studies which have shown, done in Ramadan. It has shown that with glibenclamide, all 4 studies have higher rate of hypoglycemic episodes. So if you can avoid glibenclamide during Ramadan, that is advisable. I know that in certain places it's difficult because it's a cheap sulfonylurea available in certain countries, and you cannot avoid this sulfonylurea. But if you can, you have to avoid glibenclamide during Ramadan. The second generation sulfonylureas like gliclazide and glimepiride can be safely used during Ramadan. And the hypoglycemia related to gliclazide and DPP-4 is almost similar in 2 or 3 studies. When patients are taking combination of oral therapy where you have secretagogues in the combination, then you have to adjust all the drugs in the combination. You have to adjust the doses of all the drugs in the combination. And if they are taking insulin with metformin or other drugs which don't cause hypoglycemia, again with insulin can cause hypoglycemia. So you have to adjust both the metformin as well as insulin. If they are taking basal insulin, you have to reduce the dose by 30%. And if they are taking BITS therapy, then you have to, BITS therapy meaning sulfonylurea in the morning and bedtime insulin. And in that case also, the doses of both sulfonylurea and insulin has to be adjusted. If they are taking pre-mixed insulins, again, morning dose will be shifted to iftar in the evening. And in well-controlled patients for first few days, slightly reduce the dose and then adjust according to glycemic control. And if they are taking in the evening dose will be shifted to sahur and will be halved. Similarly for R and N insulins, that is free-mixing insulins, then again, morning dose will be shifted to iftar and the evening dose will be taken at sahur and will be halved. In the evening, the short-acting insulin will be given full dose of short-acting insulin, but for NPH, you have to slightly reduce the dose for first few days in well-controlled patient and then adjust according to the glycemic control. The third point is about monitoring, glucose monitoring during Ramadan, and the recommendations to break the fast. This is again a study which is the similar study as I have discussed earlier, where the questions we have asked from patients that, do you monitor your blood sugar level during Ramadan? 30% of the patients were saying that they don't monitor blood sugars level during Ramadan. Okay, fair enough. Maybe 70% of patients are then monitoring. When we asked them what was the frequency of glucose monitoring during Ramadan, 60% of the patients were saying that they have checked sugar once a month or maximum of thrice a month. So this was the state of affairs of our patients. They don't frequently monitor the blood sugars during Ramadan, and this is the point where we have to educate our patients that they have to monitor the sugars during Ramadan, which is absolutely necessary. And this is more alarming that 18% of the patients in that study actually felt hypo and didn't check their sugars and continued the fast. So this is very alarming that people have hypoglycemic symptoms and they are not monitoring. They may be having misconception that checking the sugar can break the fast. And we have to remove this misconception that checking doesn't break the fast. So they can check their sugar as many times as they want. And for first few days, they have to frequently monitor their sugars, especially when they have symptoms of hypoglycemia or hyperglycemia. The target blood glucose levels during fasting we recommend is between 100 and 200 milligram per deciliter. As we are anticipating hypoglycemia during the day, so we want to keep the targets slightly relaxed during the day. But during the night, we are anticipating hyperglycemia, and we then have to tightly control them during the night, because during the night they are eating and drinking, so you can tightly control them during the night, but during the day you have to slightly relax the targets. So to prevent hypoglycemia during the day, to prevent hyperglycemia during the night. Regarding levels at which they have to break their fast, it is now the consensus published in this DAR IDF guidelines, where all of us have agreed that if they drop to less than 70 milligrams per deciliter, they have to break their fast, whether it occurs in the morning or in the evening. Regarding hyperglycemia, if they have more than 300 milligrams per deciliter of their blood glucose levels, then they have to consult their physician, and they have to break the fast only if they are symptomatic and they are going into DKA or having abdominal pain, vomitings, dehydrated. If they are with symptoms, then they have to break the fast. So you have to individualize each patient and see whether which of those patients have to break their fast. It is not the figure you have to treat the patient. And if the patient is symptomatic on 300, then they can break the fast. Regarding dietary and physical activity recommendations, this is from the guidelines, the newer guidelines of IDF and DAR International Alliance. There are 10 principles of Ramadan nutrition plan. First of all, we have to divide an adequate amount of calories between sahur, iftar, and if necessary, between 1 and 2 snacks. And we have done this study. One of our study was published in Diabetes Care, where we have distributed the carbohydrate intake into three times. So those patients who have distributed their carbohydrates intake into 3 times, like taking at iftar, some of the calories at iftar, then at dinner, and then at sahur. If they divided these their carbohydrate intake into these 3 times, then they were well controlled as compared to those who have taken all of the things at one time. So carbohydrate spacing is one of the idea we got from that study. So that is very important. Then meals should be balanced with 45 to 50% caloric intake from carbohydrate group, 20 to 30% from protein, and less than 35% from fat. And Ramzan plate method, I will show you the plate method. It's a nice idea to have a plate method of taking your calories. Then you have to avoid sugar heavy desserts. Okay, so that has to be avoided, of course, in diabetic. And they have to take low glycemic index, high fiber carbohydrates. And we have to talk about hydration as well, because these are summer days and the fasting is prolonged, 15 hours, 16 hours, in certain countries, 19 hours of fasting. So hydration is important. So we have to discuss this with our patients, that they have to take during their non-fasting hours, they have to take 10, 12 glasses of water to compensate for depletion that has occurred during the day. So they have to replenish their fluid intake during the night. And it is also advisable that they have to take sahur as late as possible. That is the last 1 hour before Fajr prayers, before the call for prayers. Then it is also advisable that they have to take adequate protein and fat at sahur, because these are slowly digestible items. So these diabetic patients have to concentrate on protein group and fat group in order to avoid glycemic disbalance during the day. Then it is also advisable that they have to begin their fast with water to rehydrate, and they can take 1 to 2 dates, medium-sized dates, to raise their blood glucose. And now, of course, the potassium is also, dates are also rich in potassium. So at iftar, you require potassium as well. So these are good sources of calories as well as potassium. And low caloric snacks such as fruits, nuts, or vegetables may be consumed between meals. Regarding physical activity recommendations, we say that those who offer Taraweeh prayers, they don't require separate exercise or separate sport activity. If they are doing Taraweeh prayers, then that is enough physical activity. But those who want, in spite of doing Taraweehs, they want physical activity or exercise, they can do that during the night and avoid exercise during the day, especially 1 hour or 2 hours before Maghrib prayers. The final question: is Ramzan specific education compulsory for patients, for doctors, for diabetes educators? This was a study I was mentioning earlier. This is published and regarding awareness of our patients. Very interesting findings from that study. It was asked from patients, do you believe that needle prick for testing your sugar level in the blood is not allowed while fasting? 28%, this is data of around 1,000 patients with diabetes from 2 big centers. 28% of the patients were saying that it is not allowable to check their sugars during fasting. So this was a misconception. Then the question was asked, insulin injection should not be taken at sahur as it will cause low blood sugar during fasting. 54% of the patients were saying yes, they should not inject insulin before sahur. And 45% of the patients were saying the double dose of insulin injection for diabetes should be taken at iftar and it should not be taken at sahur. So these were the misconceptions among our patients. 53% of the patients were saying normal physical activity should be resumed only after iftar. It should not be during the day. So during the day, they have to sleep and only during the night they have to do physical activity. This was a misconception. Then again, this was about patients, but we recently published a paper in which we have looked into the awareness of our doctors. What are their beliefs? And you can see that 16% of the doctors were saying that patient with diabetes should never fast. 30% of the doctors were saying that even if they drop their sugar below 70, they should not break their fast. 18% of the doctors were saying that checking sugar level during fasting is prohibited. 24.8% of the doctors were saying that taking insulin injection during fast breaks the fast. 16% of the doctors were saying that no adjustment in drug dosage and timing is needed for patients with diabetes who fast. 68% of the doctors were reducing the morning dose to 75% and night dose to 50%, which is actually the other way around. So that was about the awareness at doctors level. And then we published this article also where we compare patients seen at primary care level and patients seen at tertiary care level. The education or awareness level of patients seen at tertiary care level was significantly better than patients seen at primary care level. And maybe the reason is that at primary care level, the doctor is very busy and has to see a lot of patients. So the comprehensive education is not given at primary care level, and many things are missed in the pre-Ramadan education. Then we published also this article where we educated the doctors. We trained the doctors how to educate their patients in 10 centers. It's a prospective study from Pakistan where we trained the doctors, and they in turn, they educated their patients, and we found significant improvement in the care of these patients. You can see that implementing the guidelines, the management recommendations, 80% of the type 1 and 90.5% of type 2 have changed their dosage and timing during Ramadan. On development of hypoglycemic symptoms, blood glucose was checked by 100% of type 1 patients. So you can see people were not checking in the previous study, but now they have checked. 100% of type 1 were checking their sugars when they developed hypoglycemic symptoms, and 70% nearly of type 2 patients were checking their sugars when they had hypoglycemic symptoms. When they got hypoglycemia, you can see 33.3% with type 1 diabetes broke their fast, and 48% of the type 2 patients broke their fast when they developed hypoglycemia. This is as a result of education. Previously, they were not breaking their fast, and they were continuing their fast in spite of developing hypoglycemia. On development of hyperglycemic symptoms, blood glucose was checked in 100% of type 1s and 78% with type 2. So you can say significant improvement with the education. And breaking the fast due to hyperglycemia, although type 1 have not broken their fast, but type 2, 18% of them have broken the fast when they develop hyperglycemic symptoms. Majority of patients with type 2 diabetes change their lifestyle or physical activity from moderate to severe level of activity before Ramadan to light physical activity during Ramadan, a significant change in their lifestyle. There were no hospitalization noted, no ketoacidosis, no hyperglycemic hyperosmolar states. So with education, you can have good results. So education is considered as an essential component of successful diabetes management. And there is evidence that Ramadan-focused education program can benefit patients in terms of glycemic control, weight loss, and reduced risk of hypoglycemia. Education is needed for patients as well as physicians. So patient education includes the risk assessment of our patients, glucose monitoring, medications, nutrition, and exercise. And we have to discuss this with our patient that injections don't break the fast, and checking the sugars doesn't break the fast. And it is very important that these misconceptions have to be removed from our patient. And these are the key areas I have already discussed: that risk stratification, blood glucose monitoring, fluid and dietary intake, exercise advice, medication adjustment, and levels where they have to break the fast. These are the key areas where we have to discuss with our patients. And remember, these things are only possible when you prepare these patients 2 months before Ramadan. That is, from Rajab, you have to start preparing them for Ramadan. If they want to fast, they have to come 2 months before Ramadan to decide whether they can fast, and to have a better control, and to have education regarding Ramadan management. And patients are also advised to monitor the blood glucose frequently while fasting, because fasting, this misconception that checking the sugar will break the fast this misconception has to be removed. Several times of the day, they can check: before sahur, after sahur, at midday, in the afternoon, before sunset, and after the evening meal, and at midnight. These are the different parts of the day where they have to check their sugars. Especially they have to be educated that they have to check their sugars if they develop symptoms of hypoglycemia or hyperglycemia. And this is our latest study which was done in 7 countries, more than 6,000 patients. Again, on the pattern of EPIDAR study, where we have noted the experiences of our patient who fasted during the month of Ramadan. This is already published in International Journal of Clinical Practice. And what we found in this study, very interesting findings. Actually, we got the data when we were analyzing this data. We found that there are 2 groups. One of the group which has not received education before Ramadan, and the other group which has received education before Ramadan. So we thought maybe it's a good idea to differentiate between the 2 groups: those who have received education before Ramadan and those who have not received education before Ramadan, and see the differences. So you can see that in this slide, there's the monitoring during Ramadan, and you can see the patients who were educated, they were monitoring more than monitoring more than the non-educated group. And the frequency of monitoring was also higher in patients who were educated than the patients who were not educated before Ramadan. Drug dosage and timing alterations before Ramadan were more in patients who have received education than patients who have not received education. Although the symptoms of hypoglycemia was similar in both the groups, it was not statistically significant difference, but the rest of the differences were statistically significant. Then frequency of hypoglycemia was more in the educated, non-educated group than in the educated group. And when they developed symptoms of hypoglycemia, there was more glucose monitoring in the educated group than in the non-educated group. Again, the differences were statistically significant. When they developed symptoms of hypoglycemia, patients who were educated, they have broken the fast more than the patients who have not received education before Ramadan. So you can see the advantage of education before Ramadan. Regarding symptoms of hyperglycemia, there was not much difference between the 2 groups, but the frequency of symptoms of hyperglycemia was more in the non-educated group than educated group, and the sugars were checked. If they developed symptoms of hyperglycemia, more checking was done by the educated group than the non-educated group. And when they developed symptoms of hyperglycemia, more patients broke the fast with education than non-education. So we concluded from that study that Ramzan-specific diabetic education is the cornerstone of safe fasting. Severe acute complications of diabetes requiring hospitalization were observed significantly less in patients who received education. Ramzan-specific management recommendations were followed more by the educated group. So final slide, what we have to do before Ramadan, address the following issues. All of the following issues are important, so you have to discuss all of this with your patient. That is the risk of fasting, if they have any risk, the symptoms of hypoglycemia and hyperglycemia, whether they know what are the symptoms of hypoglycemia or hyperglycemia. We have to talk about monitoring of blood glucose, especially if they develop symptoms. And we have to talk about dosage and timing alteration during Ramadan. We have to talk about diet and fluid intake during Ramadan. We have to talk about physical activity during Ramadan. And we have to talk about what are the levels at which they have to break their fast. Ramzan study group was established by Bakai Institute of Diabetology and Endocrinology in 2008. And since then, since the last 10 years, we are striving for these aims and objectives. Our aims and objectives of this group were to educate patients, doctors, diabetes educators about Ramzan-specific recommendations, to develop Ramzan-specific education material, to conduct research in the field of diabetes and Ramadan, and to develop a website for educating the people with diabetes regarding fasting in Ramadan, and to conduct a multinational, multi-center studies in order to develop evidence-based guidelines for safe fasting in patients with diabetes. Alhamdulillah, all of these aims and objectives, we have done several of the things which we aimed in the beginning. And these are public awareness programs which we annually do. And this is the picture from this year program which we did last Sunday. And many of our patients attend this program. You can see the full hall with patients asking their questions, and the material was given to them. The education material was also distributed among them. You can see. And we, since last 5 years, we are conducting workshops for our general practitioners who see these patients very frequently, and we have a very nice program. We have very good feedback from general practitioners. This year we did workshops at 7 different cities of Pakistan, and since last 5 years we are training these doctors before Ramadan. And we are part of DAR and IDF DAR International Alliance. And we, since 3-4 years back, since the beginning, we are part of DAR, and we are also part of the guidelines which were published last year by IDF and DAR International Alliance. We are authors and co-authors of those guidelines. I thank you for your attention. Questions? This was a wonderful presentation. Thank you to sum it up. It's really crucial to keep in mind. So, more questions for Daing? Thanks for your comment, Shahid, that you have appreciated the studies which I have presented. Do you have any question? You can ask. Thank you.